Good morning. This is the House Appropriations Committee. It is Thursday, May 21st, 2026. It's 10 a.m. And we have today, I think, our final three bills. Don't hold me to it, but that seems to be the case at the moment. So we are going to do right now S-190, which is related to the Green Mountain Care Board and reference-based pricing. It's a healthcare bill. At 11:15, Chair Byron and others are coming in with a large amendment to the cannabis bill. So it's just as well we didn't hear it the other day because it's all changed anyway. So now we're going to get the bill we will need to vote on. And then this afternoon, there is a committee of conference scheduled for 1:15 in case you're interested in checking that out. I think it'll be fairly short. And at 2:15, we're going to have S-323, the miscellaneous ag bill, and we have a couple of amendments, instances of amendment to that bill as well. Nothing terrifically major, some just clarification and corrections as far as I can remember. So in the meantime, we're going to start with S-190, and we have Council, Joint Fiscal, and Chair Black from the Committee on Healthcare and other assorted watchers. So I think we're ready to go. So Jen, when you're ready, great, you can explain what it is we're actually doing.
Okay. Good morning, Jen Carpy from the Office of Legislative Counsel. And I just sent that separate document to Autumn in response to the Zoom link you sent me. That is the other document you can post for now. So we are looking at S-190, which is a bill that came out of the House Healthcare Committee. This is a strike-all amendment. And as I mentioned before we started, I will be flipping between two documents over the first couple of sections because there is a proposal of amendments that will come up on the floor. And so for you to be able to understand what that is in context, I will share that with you. And I just sent it to Autumn, so that will be going up, I think, on your web shortly, but if you don't see it yet, that's fine.
Okay, so we're going to have the bill, we're going to hear what the amendment is that they're going to propose from the floor, and we're also going to hear what our amendment is. So we have various pieces.
Hopefully we'll do that third piece last because I'm waiting to get it back from editing.
Okay, great. Yeah, then.
So tell me about the amendments from the committee. Or were they going to be in our emails, or how are we going to be able to reference them? Are you going to have to put them on the screen?
I just posted it to the.
Yes, I sent it to Autumn.
Okay.
She has posted it.
And I can print it out.
Okay, so we're going to start with the bill draft 3.3.
Yes, with 3.3, which is the full committee report.
Okay,
And this is S-190 as recommended by the Committee on Healthcare. As it came from the Senate, it is an act relating to the Green Mountain Care Board, reference-based pricing, and studying the creation of a public employee health benefit authority. But as with the bill that we went over together yesterday, there will be a title change by the time we get to the end of the bill that takes out the reference to that public employee health benefit authority, because that is not in the House, that House Healthcare's recommended version. We start off dealing with reference-based pricing, which some of you may remember from previous discussions, is the idea of having, as it was spelled out in last year's Act 68, would have the Green Mountain Care Board establish the maximum amount that hospitals could receive for various services. And so that would put caps on what the money flowing into hospitals from payers in the system. So
just to back up, last year we passed a bill to say, let's get started on reference.
Exactly.
That was step one. This is step two.
Step two.
Yeah. Okay.
Or step 1.5. So we are start off by amending the statute that authorizes and directs this implementation of reference-based pricing. As you can see, the existing law says the board shall establish reference-based prices, the prices based on a percentage of a reference that represent the maximum amounts that hospitals can accept as payment in full for items provided and services delivered in Vermont. This is current law, but just reminding you what that looks like. And new language on page 2 would direct the board to use reference-based pricing to reduce hospital prices incrementally until they equal national median prices by hospital type by calendar year 2030, using high-quality, nonpartisan data showing prices as a percentage of Medicare to evaluate progress toward reducing hospital prices in Vermont to the national median. In the language passed last year, it directed the board to begin implementing reference-based pricing as soon as practicable, but not later than hospital fiscal year 2027. Hospital fiscal years run on the federal fiscal year. So I think that's probably a concept this committee is familiar with, but that starts in October. Fiscal year 2027 starts in October of this year. And so this would require for provider contracts entered into, amended, or renewed beginning on or after January 1st, 2028. Hospitals and insurers would begin expressing as a percentage of Medicare or another benchmark, if that's what the board chooses, the rates for items and services identified through a collaborative process between the board and representatives of Vermont hospitals. So this section and this next language we're going to look at is starting to move the way we express prices to using, I'll say, Medicare benchmark price, or percentage of Medicare as the benchmark. It may not.
We express those prices too.
So in this case, it's provider contracts, so hospitals and health insurers. But the next one, starting on line 13, is that when making public the charges for items and services as required by federal law, so this is public facing, hospitals shall include in their machine readable files pricing information shown as a percentage of Medicare rates as well as actual dollar amounts. It's aggregated by payer and by plan. So that's a little more public facing too.
Yeah.
Right. And then it says for purposes of those two pieces, the provider contracts and the public price transparency, a hospital may express rates as a percentage of Medicare based on the hospital's own experience of Medicare, the hospital's actual reimbursement rates that they receive from Medicare, until such time as the Green Mountain Care Board adopts a rule establishing the methodology for determining Medicare rates kind of on a standardized basis across the board as a benchmark and establishing a reference-based price. Then it requires hospitals to apply for, obtain, and use a unique national provider identifier on all claims filed after October 1st, 2027 for reimbursement or payment for services delivered at an off-campus department of the hospital that is distinct from the one that's used for the main campus of the hospital or any other off-campus hospital department. So it starts to become easier to determine whether services that are delivered through the hospital are being delivered at the hospital or in an off-campus site of the hospital. And there's a federal requirement that this begin in January of 2028. So the original date in the bill had been earlier, but the hospital is asked to put it closer to when they're going to be required to do this to comply with federal law. Sections 2 and 3, as passed the House Healthcare Committee, are the ones that are going to change or proposed to be changed in the amendment that we're going to look at. So we're going to look at this language a bit, but then we're going to jump over to the amendment so that you can understand what the difference is. So we're now in 18 VSA Chapter 221, Subchapter 7, which is the hospital budget review process. And this would amend the subchapter. So doing statutory language here in the amendment, you'll see it's not changing statute. It's just a short-term 1-year session law provision. So this would add a definition of Medicare adjusted base rate. This is what I was mentioning is kind of the future version that is a standardized Medicare payment amount for hospital inpatient, outpatient, or professional service as determined under the Medicare program, calculated prior to the application of any hospital-specific, patient-specific, or policy-based payment adjustments, reflecting only the core federal methodology used to establish baseline payment levels, which include adjustments for geographic factors such as wages. So this is different from in the first part of the bill, when we said hospitals, for now, you can use your own actual Medicare rates to calculate the percentage of Medicare. This is thinking about using a standardized Medicare adjusted base rate that would be the same across the state. And then the individual calculations would reflect what the specific hospital's percentages of that standard rate are. And then it talks about how to do that a little bit, how to do it for a critical access hospital. Basically use it as though you were not a critical access hub. So then we'd have 9459 would be a new section with limitations on hospital reimbursements for qualified health benefit plans and plans covering school employees. Qualified health benefit plans are the plans offered through Vermont Health Benefit Exchange or Vermont Health Connect.
Those are the QHPs.
These are the QHPs.
And this is the group that the federal government eliminated the premium tax credits, or some of the.
So
Some
this
people
is,
actually-
so a couple of pieces there. This is the individual and small group are both purchase qualified health benefit plans, or QHPs is what we call them for short. But subsidies are only available in the individual market, so part of that market. And the subsidies or the premium tax credits that went away were the enhanced premium tax credits available through some of the COVID era legislation. So there are still premium tax credits, but they are back to the regular ACA standards.
Okay, but the QHPs is where people who we hear about people's insurance rates went up dramatically. They were in the QHP market,
To be
probably.
fair, there are a lot of insurance rates that are going up pretty dramatically,
Yes,
but yes,
that's
so
true.
the ones that I think that you talk a lot about in this committee and in this building and that you hear about a lot in the news are these QHP rates in the individual and small group market.
I'm working off the amendment.
Okay, I'm not there yet, so don't work up the amendment yet, because I'm not,
Yeah, going with the language. However, what I'm asking is the qualified health benefit plan,
yes,
which seems to be in here as well.
yep. Everything goes.
Anyway, the point of it is those were the people who had Health Connect subsidies. Is that correct?
Those are the people who purchase plans that are offered through Vermont Health Connect for individuals with incomes below 400% of the federal poverty level who are purchasing qualified health plans. They are eligible for federal subsidies.
Okay, so that's
So that's
different from an
a
FQHC.
subset, different from an FQHC. Is that what you just said?
Yeah, federally qualified health centers. are
Yes,
different.
that's a different, that's a location where,
Different beast.
right, that's a location where services need to be provided, not an insurance.
So for individuals and who was the other?
Individuals and small groups.
Small groups, okay.
Yes, and last year you permanently unmerged the individual and small, years ago, you permanently unmerged the individual and small groups. So they're not combined together in a single risk pool. But yes, we have individuals and small groups who are eligible to purchase qualified health benefit plans through the exchange. And then we also are talking about plans covering school employees. So these are what you may hear referred to as the VHI plans. These are the plans offered through VHI. So we have various definitions in here of benefit association that's talking about the Intermunicipal Insurance Association that VHI is organized under and regulated by DFR. In this version, hospital means hospitals that are not a critical access hospital or classified as a Medicare dependent hospital under federal law or participating in a specific program, the Rural Community Hospital Demonstration Program through the Centers for Medicare and Medicaid Services. So we're talking about a subset of hospitals in this version. That's going to change in the other.
All right.
Qualified health benefit plan, we'll call it QHPs for now, has the same meaning as in the statutes on those. Registered carriers are insurers that offer plans through Vermont Health Connect, offer the QHPs, and school employee has the same meaning as is used for the Commission on Public School Employee Health Benefits. So this version addresses hospital fiscal years 2027, 2028, and 2029. And this says, in establishing fiscal year 2027 hospital budgets, the board, meaning the Green Mountain Care Board, may direct an amount equal to 3.5% of the hospital's combined commercial net patient revenue based on approved fiscal year 2026 hospital budgets. So we're going for 3.5% of a defined pool, a defined amount toward reducing commercial reimbursement rates for the QHPs and the VHI plans based on a percentage of the Medicare adjusted base rate determined by the board for each item provided and service delivered in Vermont to enrollees in these plans. I'll pause here for a minute. to sort of recap this one. This is saying for hospital fiscal year 2027, the board can direct an amount, a specific dollar amount that is arrived at in a particular way, to reducing commercial reimbursement rates for QHPs and VHI using reference-based pricing. So this is doing some limited reference-based pricing for these plans for hospital fiscal year 2025.
Sort of
That's
easing,
27.
it's easing in other words, not
Yeah,
just
so the Green
complete.
Care Board has to adopt a rule on it for rate setting. It has to adopt rules under the Administrative Procedures Act to spell out what reference-based pricing looks like. This is starting them off with a defined amount and a defined group of hospitals and a defined set of payers.
John has a question.
Yeah, just real quick, and I may jump in with a couple of questions along the way here too, just in terms of the impact, potential impact or predicted impact it would actually have on hospitals.
If you're going to talk numbers, I'm going to
Yeah, and you're.
need to phone friends. Okay.
So I just don't know if that was information was discussed in committee, that being a question. I mean, this is.
Happy to talk about that when we get there.
Okay.
Great. All right. So then for fiscal year 28 and 29 budgets, again, this is the bill that came out of House Healthcare. It allows the board again to limit commercial reimbursement rates for QHPs and VHI plans to not more than the following percentages of the Medicare adjusted base rate for items and services delivered in Vermont to enrollees in those plans. So for hospital fiscal year 2028, that would be not more than 300% of the Medicare adjusted base rate. And for hospital fiscal year 2029, not more than 250% of the Medicare adjusted base rate.
So this is how much they can charge.
This is right, but how much they can get paid by the
Get paid,
QHPs and
yes.
VHI
Not the same thing.
be capped. Right. We're
Okay.
actually going to get to a portion of that issue at the end of the bill. And then it directs the carriers and VHI not to reimburse or agree to reimburse a hospital more than that cap, that percentage of the Medicare adjusted base rate set by the Green Mountain Care Board for the applicable hospital fiscal year for any item or service delivered in Vermont to someone who's in a QHP or a VHI plan. And it goes into some of the specifics about if it's not a fee-for-service basis, then how does that work? Do you have a question?
Yeah, instead of skipping over, define the difference between paid and charged. I think I know, but in the question, I'll ask another question maybe if it's.
Okay, to give a very sort of blunt example, I would think of it a little bit like car prices, where the MSRP is not maybe what you end up paying in the end. So the hospitals have a charge master list of all of their charges, and that is generally a starting off point for negotiations with insurers and others about what percentage of that is actually going to be paid.
You get a tax deduction for the rest of the day they don't get.
I don't believe that's how that works.
Nonprofits.
Right, for
Well,
when they are, right,
tax.
all nonprofits.
Interesting thought. But so, for example, I had some procedure done and they said, their rate was $1,100 and Medicare said it would pay $300. So there's the charge and there's what they're getting reimbursed. And then my amount that I would pay was $30 or something like that. So when you get your explanation of benefits or EOBs, you see all of those numbers.
Right.
And I'm always astounded by what the hospital's charging versus what Medicare is willing to pay. So, yeah.
You're going to see that specific issue come up at the end of the bill.
Okay.
So what I hear you saying is that you're using language here like on line 2 or line 4 of page 7. You're on page 7.
Yes.
There you are. Is that basically the adjust base rate is really the Medicare payment. I mean, it's not this, right now it's probably not the same thing. If you're using Charge Master, then they pay you whatever Medicare pays, but you're using the Medicare payment as that goes with the 300%.
Yes, and that's the concept of reference-based pricing
Yeah,
as well.
so
Yes.
should it all just say Medicare payment?
No, because each hospital has a different experience of what they actually receive from Medicare,
Based on
depending
what
on the
they are.
type of hospital that
Yeah.
they are. So that is where we come up with this concept of the Medicare adjusted base rate, is trying to come up with a kind of a standard, what we can consider to be, everybody's using the
Yeah,
same
yeah.
numbers as the rate by which to calculate percentages on
Okay,
top
so what I
of.
see is that you're taking it, you're decreasing what they're gonna get paid, and you go from 3.5 of the net patient revenue to 300% of, to 250%, that's a.
Right, it's not 3.5% of their,
Well,
their
that's
actual net
different.
patient revenue,
Yeah,
but
that's-
yes, it is, and I think I've heard it's, somewhat close to 350% of Medicare, the Medicare adjusted base rate, so you could sort of, I find it more helpful to think of it, especially since it's going to be proposed to change completely, and what I'm going to show you in a few minutes from.
Okay.
Don't get too attached to what we're hearing at the moment. Okay. All right.
All right, so we have told the payers not to pay more. It's on page 7 at the bottom, prohibits a hospital who's getting reimbursed in accordance with those provisions from balance billing. They're not allowed to collect more from the patient than, except the cost sharing that's allowed under the plan, but they're not allowed to try to make up for what they didn't get based on the percentage of Medicare from the patient. And then it says if a hospital is required by the board's budget order to reduce its commercial reimbursement rates by more than what would be achieved by using that reference-based pricing, then the hospital is directed to reduce its commercial reimbursement rates that are more than 500% of the Medicare adjusted base rate, or if it doesn't have any commercial rates that are more than 500%, then by reducing its commercial reimbursement rates that are the highest in relation to the Medicare adjusted base rate. So if the hospital is still supposed to take more money out of its commercial rates, then it's directed to focus on the highest ones in relation to Medicare.
I apologize. Could you repeat that for me? The beginning of it was most.
Sure. So in their budget orders, the board may direct hospitals to reduce their commercial reimbursement rates. If they're being directed to if a hospital is being directed to reduce its commercial reimbursement rate by more than what's going to be achieved, so I have to take more money out of their rates than what will be achieved by using the reference-based pricing
Thank you.
that they were being directed to do, some hospitals were being directed to do, then the hospital's directive from the legislation is to focus on their commercial reimbursement rates that are the highest in relation to Medicare. So if they have anything over 500%, reduce those ones first, or anything else that is higher. As a
Thank you.
percentage of Medicare.
Okay. John?
So would that be, would something like that happen due to a periodic review, a once a year review, or if they're, I don't care what's tracking this, because they get all their information here.
Well, they do an annual budget. I mean, they do an annual budget review and
Outside of that.
order.
Outside of that.
This is really in
I mean, all the hospitals put a budget together based on the budget guidelines here. That
Right.
gets approved at one time. But as time goes beyond that, is there something in here that would identify when that check may happening, as you just referenced in the language you just read?
when what would, I'm sorry.
Adjusting commercial rates of a hospital with what they're charging.
I think I'd have to defer to the board on the timing of
It'd be nice to get that information.
their,
They would just
I
have,
just-
they just have to do it if they're, they would probably know right away from the budget orders, right, whether
Well,
or not, and
it's
then they would
more
have.
about like, so the budget gets approved, hospitals
Right.
move on with their operation
Right.
for the year, but if there's something that's exceeding what you just referenced in the language.
I mean, I think it's all about
When
complying with their
would that
budget.
commercial rate be reduced?
I
I'm
would
just asking.
presume for the next provider contract, but I'd have to look at, I'm looking to Devin Green from the hospital, who's sitting behind you. So I would imagine for the next provider contract, I don't know if you want Devin to weigh in if she has information.
Sure.
If you see something.
My question clear? Yeah.
I think I understand what you're saying, but in Vermont Association of Hospitals and Health Systems, I think what this is saying for FY 2027, the hospitals would be doing that work going forward. It's up to the medical care boards and their rulemaking authority, how they're going to do reference pricing after 2027.
checking each out.
Yeah, so maybe doing that through.
That's not
rules.
determined yet, is that correct?
Correct.
So when would that happen? When would the rulemaking happen?
Well, the rulemaking process has already, I mean, I think they're in sort of preliminary rulemaking now.
In relation to this?
Not in relation to this, because this doesn't,
Yes,
this
that's
is,
not the question.
So we have a representative from the Green Mountain Care Board organization.
Thank you, Diane Lanford, Green Mountain Care Board. I'm not an expert in this, but I think I may be able to help
Sure.
with a little bit. There is the annual budget process that you're talking about that happens once a year, July 1. The hospitals submit their budgets in August. There's a hearing, and by October 1, the board submits their orders. Hospitals have the ability, and as a matter of fact, there's a few right now that are in that process of saying mid-year, like you just do a BAA adjustment. If they need to come to the board and say, I'm either, I need it too low or too high, a hospital can request for an adjustment to their budget. That's a separate process. The reference-based pricing piece is in law last year. That the task force worked in Act 68 and is in the process of the rulemaking right now going forward. But you also wanted us to start in 2027. And so what you have before you is that measure of the beginnings of it.
So there may not be an answer yet to your question, because they're in rulemaking.
Yeah, okay.
Would Chair Black like to say something? And then I see Dave's hand also. Go ahead.
Well, I was going to, Representative Alyssa Black, I was gonna make a point when I do speak, that the impetus for this bill was because we tasked Green Mountain Care Board to begin reference-based pricing for fiscal year 27. However, they have not completed their rulemaking process yet. So in order for them to proceed and meet our legislative intent and what we did last year in Act 68, they need authority from us to begin this reference-based pricing because they're not quite completed with the rulemaking process.
Which we expected that would be the
Which we
case.
expect will have easily been done by FY 28, which you'll see the amendment. It's just for this year. And that's when this will apply.
So maybe we'll keep going and see if some of the questions get answered as we get all of it. Dave?
I apologize, I'll be quick. As a former provider and as a former regulator, I'm trying to strike a good balance. And I'm a little bit concerned because on the one hand, we're saying we're instituting this reference-based pricing. We, the government, has determined that the reference should be Medicare plus a percentage. But, and the part I asked Jen to repeat, it sounds like if the board, for some reason, wants to reduce further, they have the latitude to do that, and then the provider will go to its highest commercial rates and start reducing them. But is there any criteria anywhere? Do they just arbitrarily say we maybe it's not arbitrary, but we want to drive down premiums further? Because what I've learned is all sides covet predictability. And if the predictability from the system is gone, you can play by the rules and try to do the reference-based pricing, but then all of a sudden, somebody says, I want more. That would seem to create quite an unstable environment. And maybe I'm digressing from the principles and the purpose of the
I mean,
bill.
there's certainly a number of, speaking of principles, a number of principles that the Green Mountain Care Board are directed to follow in guiding their work. And some of that is, that balance between,
Oh, dear.
do you need to all go for a vote?
I have no idea what that's about. Hang
A
on.
good sound.
Oh, let's see, I got something. But yes,
It's, on test 230.
S 230.
It's 230.
What is that?
Fair
employment practices.
Okay,
employee recommended using.
okay. Okay. So. Is there a place where it makes sense? Is there can we just finish section 2 and then let's go upstairs? And then as soon as we're done voting, and of course, we have the last person to vote on our committee, so we'll come down as soon and start as soon as they. But let's just finish section 2 because they're.
So briefly, yes, I think there are some parameters in place that are supposed to guide the board's deliberations and how they approach hospital budgets. And they issue their
Covered.
guidance
Mhm.
as well. Okay, and then sort of finally, for our purposes in this section, this other piece relates to language in here, but it doesn't relate to the language in the amendment. It comes out, so I will move to this, which is that in its reviews of premiums, when they're reviewing health insurance proposed premium rates for the QHPs and for VHI respectively, the Green Mountain Care Board and Department of Financial Regulation are directed to ensure that the limitations on reimbursements in this section are appropriately reflected in the premiums for those plans, meaning, this is putting downward pressure on what gets, what the carriers, what the insurers pay for QHP, for services delivered to QHP and VHI enrollees. And the legislature in this is saying to the regulators, make sure that shows up in the rates. So it may not literally reduce the rates, but it may reduce the growth in the rates below what it would have otherwise been. That is the end of
Intersection.
then.
So if you want, you can bring up, we can't use our electronics, but you can read the bill while we're upstairs. And there's an amendment from various people on House Healthcare. And Autumn has posted our amendment to the board, which is a very short one. That's the thing when we're just taking it